This is Tom Sagustin. I'm one of the hepatobiliary surgeons at the Cleveland Clinic, and today we'll be talking about benign disorders of the liver and the bile duct. I do not have any disclosures regarding this presentation. So this is the overview for my lecture. We'll be discussing various benign tumors of the liver and bile ducts and how they're managed. And I'll go through focal nodular hyperplasia, hepatocellular adenoma, hemangioma, nodular regenerative hyperplasia, hepatic cyst, biliary cyst adenoma, and choledochal cyst. Now, I won't be talking about gallbladder stones, choledocholithiasis, cholangitis, hepatolithiasis. I think those are covered in other parts of the review. So first off, focal nodular hyperplasia. So the epidemiology of focal nodular hyperplasia. So these are hyperplastic hepatocellular lesions which result from vascular malformations. Notably, these are not neoplastic lesions, they are hypoplastic lesions. They're often associated with other vascular anomalies. They are the second most common liver tumor. Although they are the second most common liver tumor, they're only clinically relevant in 3 out of 1,000 patients. 90% of these patients are female. The average age of onset is 35 to 50 years. Like I mentioned before, the other vascular anomalies that may be associated with FNH include a hepatic hemangioma. Other tumors, such as a hepatocellular cancer, can also be observed in tandem with a focal nodular hyperplasia. All of these point to the fact that this is a vascular anomaly that leads to these lesions. The genetics of an FNH involves upregulation of the extracellular matrix genes associated with TGF beta signaling. Most of these patients that present to us with FNH are completely asymptomatic. So most often what you find is a solitary tumor, which is less than 5 centimeters in size. If you have the chance to look at previous scans, you will find that most of these lesions stay stable in size in most cases. Around 20 to 30% of patients will have multiple FNHs. 20% to 40% of patients may present with symptoms. Even in these patients, the symptoms most commonly are abdominal pain, usually localized to the area where the FNH exists. Complications are extremely rare with these tumors. As I mentioned before, that although these tumors are predominantly seen in females, there is no clear-cut relationship to OCP use. So if your patient is on oral contraceptive pills, they may continue to use it. Same goes for pregnancy. Does not seem to have any obvious association with pregnancy. These lesions are diagnosed mostly on imaging, and they have some very characteristic features on the MR imaging. So this is a T1 phase MRI where you can see that the tumor may be visible in the T2 phase, and you know it's T2 because fluid is white. It really doesn't show up that well. This is a contrast enhanced picture where you can clearly see the lesion, which has got a spoke wheel appearance with a central scar, and it does not have a capsule. It often has lobulated contours, and it starts to wash off in the delayed phases. So the other imaging that can be used is a CT scan, which has got similar characteristics. Now, biopsy is rarely required after an MRI has already been done because most of the times MRIs will be diagnostic of an FNH. So management of these tumors. Most of these tumors remain not just stable in size over time, and they also continue to remain completely asymptomatic. For these patients, a conservative approach is appropriate. One might consider doing an annual ultrasound for 2 to 3 years in OCP in oral contraceptive pill users to check the size, make sure it's not changed, but there is no real indication for discontinuing OCPs in these patients. Follow-up during pregnancy, as I mentioned earlier, is not necessary. For patients that are very symptomatic, one might consider intervening. These symptoms may be severe abdominal pain, symptoms related to pressure symptoms on upper abdominal organs like the stomach, obstruction symptoms. And in those patients, a partial hepatic resection may be considered. The other group of patients who may benefit from surgical resection is where a firm diagnosis of FNH cannot be established. One of the differentials in patients with FNH is a fibrolamellar hepatocellular carcinoma. And if you cannot establish a clear-cut diagnosis, then these patients may be considered for resection. Embolization and radiofrequency ablation have also been increasingly used for cases where clearly the diagnosis has been established and you're treating it for symptoms. The next tumor that we will talk about is a hepatocellular adenoma. Hepatocellular adenoma is a benign neoplasm with various types of benign hepatocellular proliferations. So they, on microscopy, will look like liver cells. They tend to develop in individuals with a hormonal or metabolic abnormality which stimulates hepatocyte proliferation. So the 10:1 female to male ratio supports that. The reported prevalence is 7 to 12 per 100,000, and it's obviously seen a lot more in females, especially aged 35 to 40 years. As far as risk factors, there is 30 to 40-fold increase in incidence with long-term oral contraceptive pill use. As androgenic steroid use has increased in incidence in males, the incidence of hepatocellular adenomas have also increased. These patients are incidentally diagnosed in around a quarter of the tumors. They will have no symptoms, but they have undergone imaging for other reasons, and these tumors are found. For symptomatic patients, very often the symptoms will be abdominal pain again. So chronic right upper quadrant pain or sometimes epigastric pain. If these tumors are large, one may be able to feel these as a palpable mass. If there is a sudden acute change in pain status in these patients, then one should suspect hemorrhage. And hemorrhage almost always happens in lesions which are over 5 centimeters in size. These patients may present acutely to the emergency room in severe abdominal pain. The molecular classification of hepatocellular adenomas has been gaining quite a bit of prominence, and this is because the molecular subtype of these is highly associated with the risk of transformation to hepatocellular carcinoma. These are the 5 main different types of molecular classification. The one that's most common is HNF1 alpha inactivating mutation, which happen in around half of these patients. This is not generally associated with a high risk of HCC transformation. The inflammatory tumor has a higher risk of bleeding, but again, not a higher risk of HCC transformation. The one that does have the highest risk of malignancy are the ones with the beta-catenin activating mutation, which happens in 5%, and the beta-catenin with inflammatory features, which happens in 13%. 10% of these tumors will remain unclassified and are generally associated with a low risk of transformation to HCC. As far as diagnosis, MRI is superior to all other imaging modalities. It is actually able to differentiate various HCA subtypes in up to 80% of patients, and there are characteristic enhancement patterns with either multi-hands or EOVIST, as we use in our institution, which are helpful to differentiate it from FNH. And this is a picture of a hepatocellular adenoma. As you can see in the arterial phases, there is clearly this tumor that's highly vascularized and shows up, and then there is washout in the later phases. Biopsy can be risky. That's because the vascular nature of these tumors and the propensity to cause hemorrhage, and it should be reserved for select cases where either you have a genetic profile or molecular diagnostic tools are available, which would allow you to make treatment decisions based on the genetics of the HCA. Every patient who has been diagnosed with an HCA needs a specialist referral and follow-up by a specialist, most commonly a hepatobiliary surgeon or a surgical oncologist. That's because the risk of HCA transforming into an HCC, which is felt to be at this point in literature about 5 to 10%. All treatment decisions regarding management of these tumors should be based on gender, size, and the pattern of progression. The first thing that needs to be inquired in these patients is OCP and other hormone use, which should be discontinued immediately, and then the patient can be followed with serial imaging. For patients who present asymptomatically, these tumors have been found incidentally and they are less than 5 centimeters in size. A conservative management is recommended, which includes imaging every 6 months for the first 1 year or 2 years, and then annually thereafter. For patients who have lesions over 5 centimeters in size and for tumors that are continuing to grow, surgical resection is recommended regardless of symptoms. Patients who present with symptoms that may include abdominal pain, or patients that may present with bleeding HCAs are recommended to undergo treatment. And in these cases, patient has treatment options including radiofrequency ablation, transarterial embolization, and surgical resection. Patients who present with bleeding HCAs with hemodynamic instability should be immediately sent to the interventional radiology suite to undergo transarterial embolization of the bleeder. After that, and after they have been stabilized and managed, these patients should be re-imaged, and if they have a residual viable tumor on follow-up imaging, these patients have an indication for surgical resection. Surgical resection is also recommended irrespective of size in all men and in all cases where there is a proven beta-catenin mutation. A variant of hepatocellular adenoma is adenomatosis. These are situations where you find more than 3 liver adenomas in the patient. Again, in general, treatment is based off the size of the largest tumor that's there in the patient. The presentation, the genetics, and imaging is very similar to solitary hepatocellular adenomas. Liver resection may be difficult to offer because of having difficulties with the size of the future liver remnant, and some of these patients may be asked for transplant. These are followed exactly the same as solitary adenomas. Now we'll move on to hepatic hemangiomas. Hepatic hemangiomas are the most common primary liver tumors. The ultrasound studies on hemangiomas have placed the frequency at about 0.7% to 1.5%. Again, these are more common in women aged 30 to 50 years, although the female to male ratio is nowhere like the other two tumors that we have discussed too far. It's around 1.2 to 6 is to 1 female to male ratio. Although it's more common in the 30 to 50-year-olds, it can occur in any age group, and there is no definite relationship to oral contraceptive pill use. Hemangiomas are rarely of any clinical significance. They are most often solitary, and they're small, less than 4 centimeters in size. Many patients, even with very large tumors, may continue to remain quite asymptomatic. Although larger tumors are more likely to be symptomatic, one does need to recognize the Kasabach-Merritt syndrome, that is a consumptive coagulopathy, which is associated with large hemangiomas. It manifests with thrombocytopenia, disseminated intravascular coagulation, and systemic bleeding. Hemangiomas have a very classic appearance on ultrasound, and most of the time, a transabdominal ultrasound is sufficient to diagnose, especially in cases where the radiology findings are typical, which include the homogeneous hyperechoic with sharp margin, posterior enhancement, and absence of a halo sign. In lesions that are less than 3 centimeters, many times an ultrasound may be all that you need to diagnose. If the ultrasound is not diagnostic, then one should consider a contrast enhanced imaging. That could be a dynamic CT, which is sufficient in many cases, although an MRI is better. And this is a picture of a hemangioma. This is quite a large hemangioma, and you can see the peripheral enhancement, which rolls over from the outside to the inside, which is very characteristic for a hemangioma. On an MRI, on a T2 phase, it appears hyperintense, and on a T1 phase image, it is hypodense. Biopsy is very rarely needed in hemangiomas. This is a pathology specimen from the previous patient whose CT scan was visualized. She was quite symptomatic from this, and she underwent surgical resection, and that's how the gross specimen looked like. Most patients who have hemangiomas are completely asymptomatic, and many of them are incidental discoveries, and they're quite often seen on CT scans and MRIs done for other purposes. There is no relationship between size and complications, or at least none that's established in the literature. Benefits of surgery is highly debatable in hemangiomas, but in patients who have very large tumors, and if they're symptomatic, surgery is beneficial. Enucleation is safe if it is possible. Radiofrequency ablation has demonstrated some success, although it is not the standard of care at this point. There is no need for follow-up imaging in patients unless the diagnosis is not certain. If patients develop new onset symptoms, then it would be beneficial to reimage them to see what has changed with the tumor. Next, we're going to talk about nodular regenerative hypoplasia. Nodular regenerative hypoplasia is a benign hepatic condition. This is where normal parenchyma of the liver has transformed into small regenerative nodules. And this is felt to be the result of ischemia, which is either related to thrombosis or phlebitis. This is something that shares common features with micronodular cirrhosis. However, this doesn't happen in the background of cirrhosis. The differentiation of nodular regenerative hypoplasia from one that happens with cirrhosis is based on the absence of fibrous septae between the nodules. This is rarely, if ever, symptomatic, and the prevalence is 2.1 to 2.6% in the general population. Because these are generally small lesions, it's very hard to differentiate these lesions based on imaging studies. It's difficult to differentiate them also from regenerating nodules of cirrhosis. So biopsy remains a definitive method for diagnosis. Treatment is geared towards the management of the underlying etiological condition that has led to the regenerative hypoplasia. Next, we'll talk about simple hepatic cyst. Simple hepatic cysts are thought to be congenitally derived. Majority of these patients have had imaging for other reasons on which these cysts are noted. So it is quite a common condition. It may affect from 2.5 to 10% of the general population. Very few percent of these patients have any symptoms, and I would think that even the 4% number is quite high, but very few percent of the patients who have cysts have any symptoms. Obviously, for patients who have larger cysts, they have a higher association with symptoms, and most of the symptoms in these patients are related to pressure on adjacent viscera. Many of these patients who have cysts in the left lateral segment of the liver will present with severe abdominal bloating symptoms, sometimes difficulty with eating, trouble with dysphagia, sometimes nausea and vomiting. A large cyst can also cause pressure symptoms with abdominal pain. Hemorrhage, rupture, and infection are all other potential cause of symptoms, although these are quite rare findings, especially in an unprovoked situation. It's unlikely that a cyst spontaneously hemorrhages, ruptures, or gets infected. Ultrasound is both highly sensitive and specific for the diagnosis of hepatic cyst. When these cysts have any amount of hemorrhage, it may be very difficult to differentiate them from biliary cystadenomas or cystadenocarcinomas, which we will talk about soon. In those cases, a contrast-enhanced imaging will be beneficial. So this is a picture of a simple hepatic cyst. Note how in this contrast-enhanced study, there is no contrast enhancement of the cyst per se. There is no complexity inside the cyst. This is the point that I was trying to make. If this if bleeding happens into one of these cysts can take on a very complex shape and form, and these complexity may mimic biliary cystadenoma or sometimes even a cystadenocarcinoma. In this patient, there was no enhancement of the material inside, thus the contrast enhanced imaging helped with the diagnosis of a cyst with bleeding. This patient was followed with serial imaging, and the cyst size was noted to decrease in size as the patient was followed. As far as management, these patients are only offered treatment for symptoms or for complications related to the cyst. Surgical intervention is quite effective in reducing or eliminating symptoms. A lot of other modalities have been tried: percutaneous aspiration, alcohol, sclerotherapy, and those just do not have uh, the cure rate that surgery can offer. So most of the time, these patients are offered laparoscopic deroofing, open being a lot less common nowadays, laparoscopic cyst resection, or laparoscopic partial hepatic resection. Laparoscopic fenestration offers the best balance of morbidity and long-term outcomes. Liver resection is very rarely needed if the diagnosis of a cyst is firmly established. Now we'll talk about hepatobiliary cystadenomas, or the newer term for these, which is hepatobiliary mucinous cystic neoplasms, or hepatobiliary MCNs. Hepatic MCNs are primary cystic neoplasms of the biliary tree. The etiology of these lesions continues to remain unclear. They are either mucinous or serous in nature, but mucinous tumors are far more common. These particular set of slides is going to focus on the mucinous cystic neoplasms of the liver. They are characterized by mucinous epithelium, which is characterized by the presence of an ovarian-like mesenchymal stroma. It is important to note that extensive sampling is required to make this diagnosis, because both the mucinous epithelium as well as the ovarian-like mesenchymal stroma may both be focal. So a small biopsy may not establish the diagnosis of an MCN. Incidence and prevalence is not clear, since most current impressions in the literature are still based, unfortunately, on earlier criteria of cystadenoma and cystadenocarcinomas. So oftentimes when these cases are reviewed, they may not have features of an MCN, or they may not be an MCN. So it's hard to tell what exactly is the prevalence. These are considered the hepatic counterpart of pancreatic MCNs. Most patients who are affected are middle-aged females. As a matter of fact, predominantly every patient is a middle-aged female. It is very rare to have these tumors in men. Approximately 90% are intrahepatic, and the remaining 10% arise in the extrahepatic biliary tree. These tumors tend to be quite large compared to other hepatic lesions, and in the largest series that exist, tumor size average greater than 10 centimeters. Symptoms most of the time result from the mass effect of these tumors. And these symptoms may include abdominal pain, a palpable mass, or elevated liver enzymes. As a matter of fact, many patients may get liver imaging because they've had blood tests done which have revealed an elevated alkaline phosphatase, or AST, or bilirubin, and they are noted to have these tumors on imaging. Complications from these tumors can include obstructive jaundice, chronic cholecystitis, and cholelithiasis. Jaundice is present in up to 1/3 of all clinically relevant cases. These are quite challenging to diagnose radiologically. So most of the time, MRI with contrast enhancement is utilized, and they have a classic picture on MRI. They are multiloculated with multiple internal septations, and these internal septations contrast enhance and are thick. The other features that are characteristic of these tumors include focal calcification, nodularity, and septal thickening, as was noted in the picture. They're very often difficult to distinguish these from other lesions such as hydatid cysts sometimes and cystadenocarcinomas. Um, this is another picture of the same patient. You can see the complexity of the cyst with multiple internal septations, and you also see a dilated bile duct coming into the tumor. Incidentally, this patient also had a gallbladder full of stones, the cholelithiasis, which is a common accompaniment. This patient underwent surgical resection and did not have a carcinoma, but was noted to have an MCN. Fine needle aspiration is not sensitive or specific enough, and absence of CA19-9 or CA cannot rule out hepatobiliary MCN. Their presence should alert the physician that it may be an MCN that the physician is dealing with. Conservative management is not appropriate once the diagnosis of MCN has been made. That is because malignant transformation can occur with these lesions, as well as the presence of a coexisting malignancy. Incidence and conversion rate to malignancy is not clear in the literature, although it may be as high as 30%. Again, these numbers are based off of older literature where there has been a lot of misclassification. Current literature would suggest that the conversion rate may be just 5%, but again, there is a significant risk of malignant transformation, so complete resection of these lesions is recommended. Now we'll talk about choledochal cysts. Choledochal cysts are rare dilations of different parts of the biliary tree. They are a lot more common in Asian population and in females. So the female to male ratio is 3 to 4 is to 1. Most of these pathologies occur in childhood. However, around 20% of cases are first recognized in adults. The most common prevailing theory about choledochal cyst is Babbitt's theory of common channel, whereby it is felt that an abnormal pancreaticobiliary junction, which causes the reflux of pancreatic juices into the bile duct, is the cause of these abnormal biliary tree dilations. This is supported by the fact that abnormal pancreaticobiliary junction occur in around 50 to 80% of patients with choledochal cysts. The most prevailing classification of bile duct cysts is the Todani classification. And I'll run through that classification very quickly. So type 1 is where you have a solitary fusiform extrahepatic cyst. So you can see this is the right bile duct, the left bile duct, the common hepatic duct, and you have one fusiform extrahepatic cyst. This happens in the majority of patients. This is what the classification of the cyst is. It's 40 to 85% you have a type 1 cyst. The second type of cyst is where you have an extrahepatic supraduodenal diverticulum. This happens in just 2 to 3% of patients. This is a type 2 cyst. A type 3 cyst is where you have an intraduodenal diverticulum. This is also called a choledococele. It's 1.6 to 5.6%. Some people argue that a choledococele is not a true choledochal cyst because it has a unique duodenal histology, a unique duodenal location and associations. Also, they tend to be treated very differently. Most of the time, choledococeles are treated with biliary sphincterotomy. So there is an argument that choledococeles are not true choledochal cysts. Type 4 choledochal cysts have fusiform extra and intrahepatic cysts, and they have multiple cysts. That's 4A. So you can see multiple cysts. There is an intrahepatic cyst, and extrahepatic cyst. When they have multiple extrahepatic choledochal cysts, they are referred to as type 4B choledochal cyst. And finally, you have patients with multiple intrahepatic cysts, and this is called Caroli's disease, where there is multiple cysts inside the patient's liver. So 18 to 20% are type 4A and 4B, and Caroli's disease is quite rare. Most of these patients have symptoms that are typically intermittent. And if you sit down and ask them, many of these symptoms are of the biliary colic in nature. And it is regardless of what type of Todani class choledochal cyst that they have. So most of these patients present with recurrent epigastric or right hypochondrial pain with fever and sometimes mild jaundice. 15% of patients may present with cirrhosis or hepatic fibrosis, and that's related to obstruction that is caused because of stone formation or sometimes related to inflammation and very rarely malignancy. Clinical pancreatitis, again, most commonly related to stone formation, is seen in 30% of these patients. A biliary tract malignancy happens in 2.5 to 28% of these patients, and the risk of cholangiocarcinoma increases with age. From 0 years to 30 years, there is almost no risk of cancer. For patients in the 50 to 70 year range, there is a 50% risk of cancer. And this is what dictates, outside of symptoms and chronic and pancreatitis, this is what dictates treatment of these cysts. Many times, labs are non-specific for investigating choledochal cyst. Ultrasound is a good initial first test. It's also a good test for long-term surveillance of patients after they've undergone surgery for choledochal cyst to see if they have a dilated duct in a post-op situation. Ultrasound is able to see a dilated ductal structure different from the gallbladder in these patients. CT scan is quite useful in showing that these cysts are continuous with the biliary tree and its relationship with surrounding structures. If there is an associated cancer, we're able to not just detect the presence of the cancer, but also stage the cancer. But MRI is the current gold standard, and it has largely superseded CT imaging and ERCP. MRCPs have almost 100% detection rate for choledochal cyst, almost 53 to 100% detection rate for anomalous pancreatobiliary junction, 100% detection rate for choledochal lithiasis, and a very high detection rate for cholangiocarcinomas. ERCP has a very limited role in managing patients with choledochal cyst, and their role is limited to mostly type 3 choledochal cyst or choledococele, as it allows biliary sphincterotomy to be performed in patients with type 3 choledochal cyst. Regardless of method, it is empiric that every patient who is being considered for surgery has a complete cholangiographic visualization of their entire biliary tree. Now, talking about management of choledochal cyst, there are some important things to consider. Surgical resection, interventional therapy, and hepatic transplantation are all available options for patients with choledochal cyst. Choice of what therapy is being used depends upon the subtype and the extent of the biliary tract involvement. But regardless of the different type of choledochal cyst, complete excision of these cysts with some form of biliary reconstruction has become the standard of care for most patients with extrahepatic choledochal cyst, type 3 being the only exception. So this is how most of these cysts are managed. So for type 1, where if I can remind you, it is a single solitary extrahepatic fusiform dilation. These cysts can be managed by excision of the entire extrahepatic biliary tree with a Roux-en-Y reconstruction, either a hepatocogenostomy or a straight hepaticoduodenostomy. In patients with a solitary extrahepatic type 2 choledochal cyst, patients can be managed with excision and reconstruction as necessary. Type 3s, as I've already mentioned, are managed with transduodenal excision, either via surgical options. They can be managed with transduodenal sphincteroplasty, or more commonly in today's day and age, with an endoscopic sphincterotomy. Type 4A cysts are more complex. Again, in these patients, they can undergo an excision of the entire extrahepatic biliary tree with reconstruction via Roux-en-Y hepatocogenostomy or hepaticoduodenostomy. And they may need partial hepatectomies for the intrahepatic portion of these cysts. Type 4B, again, pretty similar, excision with Roux-en-Y reconstruction and partial hepatectomy for intrahepatic portion with transduodenal sphincteroplasty as needed. And finally, for patients who have Caroli's disease, very often or almost always they'll need hepatic resection, Roux-en-Y to an intrahepatic duct, or orthotopic liver transplantation. So in summary, many liver masses that are discovered are incidentally noted, and this is an increasing phenomena which is associated with the widespread use of imaging studies for diagnostic workup. A significant number of these lesions are benign and they require absolutely no further intervention. Biopsy has largely been mitigated by imaging. Referral to a specialist is beneficial to appropriately choose diagnostic and management options.